Okay, and now it can go over to Cristina and John to begin.
Hi, everyone. Hi, Cristina and Maria. Professor Adam, thank you very much for being here with us. And for the audience, I would like to introduce our guest today, which is Professor Adam. It's the head of the Department of Hepatobiliary Surgery in Brousse Hospital. He's also the director of diseases and cancers of liver cancers and of digestive system in Brousse Hospital. He's also the director of the research team in chronotherapy, cancers and transplantation at the University of Paris-Saclay. He is the president of honor in the l'Association de Chirurgie Hépatobiliaire Pancréatique et Transplantation, and is the president-elect of the International Hepatic Pancreatic Biliary Association. Today, we have also Dr. Cristina Dopazo from Barcelona, and she is going to be together with us to share this session. So, Cristina.
Thanks to everybody. Thanks to DESO for this initiative and EYSAC also. So it's just a great pleasure for me to co-moderate this session. I introduced Dr. René Adam. I think it's like a hot topic for us, for all the HPV surgeons. It's a lead to follow, and hope that you will join and enjoy the sessions today. Dr. René Adam, hope you will show us like to be a great HPV surgeon. Thanks a lot.
Okay, thank you. So may I share my screen? So I will do this. Okay. Do you see my screen?
Yeah, great, Dr. Herrera.
Okay, so first of all, I would like to thank you, Cristina, John, and also the European Society of Surgical Oncology for inviting me for this prestigious, I would say, talk. When I see the title, I was a little bit amazed to be a potential legend in surgery. So living legend, living yes, legend, I'm not so sure. This is the first point. And the second point is that I don't like so much to speak of me, but you obliged me to do it. And I will try to focus on what I have learned from all my career, in a way up to now, because it's not finished, of course. And I will try to focus on some advice for the future to you. So if I begin this, I will begin before medicine. I was born in 1955 in a foreign country for me. It was Casablanca, Morocco, because my father was working in a French factory there. It was a modest family. I have no previous doctor in my family. I was learning primary and secondary studies in a French college. And at 17 years old, at that time, I need to go to France for universitary studies. And at that time comes the first question in my life. I have passed two types of concourses, one for engineering and another one was the possibility to do medicine. And so I choose medicine at that time because, of course, it was for me the best possibility to have the largest possibility of choice. And so I study initially medicine in León, University of León, and 2 years after, because my family was moving from Morocco to France, I go to medicine to studying medicine in Paris. In 1978 was an important, I would say, point of my career because I passed at that time the concourse for being resident of the Paris hospital. It's a difficult concourse because only 10% of the candidates were finally chosen for being a resident of Paris hospital. And so from 1978 to 1985, I was a resident in Hôpital de Paris, interne des Hôpitaux de Paris. This was the French denomination of this. And I was a resident in surgery from the year of 25 to 30. And then during my residency, exactly as the first year of my residency, the first chance, I would say, of my career, because in fact, I was absolutely not determined about the choice of my specialty. And I began, because I think it was interesting, to intensive care unit, resident in an intensive care unit in the department of HPB surgery in Brousse Hospital. And this was, in fact, the department of Professor Henri Bismuth. And there was a sort of mixture of surgery, intensive care, medicine, and the richness of the multidisciplinary staff meetings, the rigor of reasoning, the patient, and the excellence of care make me admirative of Henri Bismuth. And at that time, I switched completely from ICU to surgery, and I decided, because of course it was a hepatic surgery department, to become an HPB surgeon. And so this was in 1978, and I go to be resident in 8 different surgical departments of the hospital in Paris. And then after this, I become, I would say, a medicine doctor in 1985. And I pursue, I would say, all the courses, the usual courses at clinical head, assistant surgeon. And the second chance in these, I would say, in all these parcours was the fact that I was not promised to have a university or an hospital careers. I remind you that in France, it's very difficult to stay in the hospital, in the university hospital, because it represents less than 5% of the surgeon. And I had at that time no possibility to, I would say, to continue to stay in the department of surgery of Brousse, because there was so many surgeon candidates. And I had at that time no real mentor. Of course, I was respectful for Henri Bismuth, but Henri Bismuth, you know, around Henri Bismuth, there was a lot of candidates to continue their career into the hospital. And I was not so the first elected candidate for that. But I said to myself, I'm doing what I like, what I love, and I was working a lot, also not only on the week, but also all the weekend. And I had a clinical and research investment in surgery and transplantation, so large that it allows me to do a lot of publication. And because of that, I acquire a sort of recognition from all, I would say, the HPB community in France, in such a way that 3 different centers in France promise me, offer me the possibility to go in their city. It was Besançon, it was Rennes, it was León, Grenoble, and so they offer me to recruit me and to make me professor in a very short period of time. And because of this, Henri Bismuth take, I would say, the knowledge that he should do a big effort to nominate me, and if he wanted me to stay in the department, and it made it. And I become not only professor of surgery in 2004, but professor of surgery in the department of Paul Brousse Hospital, under, I would say, the supervision of Professor Henri Bismuth. And I was at that time 39 years old and very happy to work in, I would say, my native as a surgeon department. So then after this, I continue, I would say, what is usual in the career of a professor, first class, exceptional class, and I become in 2012, I become head of the hepatobiliary cancer and transplantation unit. And then finally in 2016, I become head of the department of surgery because Henri Bismuth and then Denis Castin had retired, and I succeeded I was the successor of the head of the department after them. And so the third chance that I had in my view in my career was to continue on the patient. And continue on the patient, I was pursuing all the clinical activity, very intensive in my department of liver surgery and liver transplantation, doing probably a little bit more than 1,500 hepatectomies, more than 1,000 liver transplantation. And this mainly for the treatment of primary and secondary liver cancer with the combination of chemo and surgery, by also developing research. And this was also an important chance that I had because I'm presently head of a research team at Paris-Saclay University, which is the first university in France in the Shanghai ranking, about chronotherapy, cancer, and transplantation. And this unit is especially devoted to innovative projects on biological rhythm, on fast-track surgery, medicine, and optimization of liver function with machine perfusion in liver transplantation. And finally, also think an opportunity that I had and that I developed is to try to improve the knowledge by collecting big data cohort. Since more than 20 years, I'm general manager of the European Liver Transplant Registry, which account for more than 170,000 patients transplanted in all the institutions from the 32 countries in Europe. And I decided also to found in 2005 an international registry of colorectal liver metastasis, whose name is LiverMed Survey, which has collected now a little bit more than 30,000 operated patients. And you have here an illustration of this. This is the European Liver Transplant Registry with the number of transplantation, the number of centers, the number of countries. And this is give, I would say, an exhaustive representativeness of liver transplantation in Europe. And it has become a real reference of what is the evolution, the indication, the result, the outcome, even at more than 20 years of what is liver transplantation in Europe. And also this is LiverMed Survey, the International Registry of Surgically Treated Patients for Colorectal Liver Metastasis, which account for a little bit more than 30,000 patients in a lot of centers and a lot of countries, because this is not European, but it is also international. And you have many, I would say, non-European countries that contributed also to LiverMed Survey. And I know that Spain is, with Italy and France, the best contributors to this international registry on the colorectal liver metastasis. Now, what I would like to mention to you is that you will see that in your career, sometime you may have a chance, and this chance may be provoked by the necessity. And just I will give you 3 examples. 1988, we have a preliminary experience with oxaliplatin in Paul Brousse Hospital, a drug which was totally abandoned by a French pharma because it high neurotoxicity, and re-explored by the oncological team of Paul Brousse Hospital, because at that time, Francis Levy was an oncologist who totally convinced that chronomodulated chemotherapy may decrease toxicity and efficacy, and we have a real proof of that. And so at that time, we had a weekly meeting with 2 medical oncologists, a radiologist, and me as a surgeon. And this was the ancestor of a tumor board meeting, in fact, to discuss the resectability of patients receiving FOLFOX. And at that time, we were probably one of the first team in the world using oxaliplatin, and we were faced with such type of fantastic, I would say, downsizing of tumor in the liver, colorectal metastasis. And at that time, the alternative was what to do: to continue chemo, which was a standard therapy at that time, because we don't change who win. And so all the oncologists in the world who observed this was saying we continue chemotherapy. But the possibility was also, and this was the question I asked to the radiologist and to the oncologist, why not to go to surgery? And so because of the fantastic effect of oxaliplatin FOLFOX at that time, the oncologist said to me, why not? Why not? You can try to do a resection of this patient. And this was the experience that we reported about the resection of initially non-resectable patient. And I should say you frankly that when I was presenting this at Congress, everybody was saying, oh, this is anecdotal, this is only in Brousse, it's so rare to have such type of big effect and so on, that it has no real, I would say, critical issue. It's not a critical issue for the majority of patients. However, we published in Annals of Surgery in 2004 this first experience showing that indeed we were giving to patients with initially non-resectable patient survival at 5 years of 33%, which was lower than that of patient initially resectable, of course, but which was significantly much better than patient who was continued chemotherapy without any surgery. And so I was very happy some years after to see that in LiverMed survey, more than 4,000 patients have been operated after being considered initially unresectable, you know, with exactly the same survival advantage. And today, it is well known that this principle of resecting a patient initially non-resectable but downsized by chemotherapy is I would say, convenient strategy to adopt in such type of patient. And so this is what I may call chance and necessity. So the second point that I want to emphasize in my career is, I would say, also chance and necessity about a problem. 1995, chemotherapy with FOLFOX has gained efficacy and credibility. We know at that time that 15 to 30% initially unresectable patients become resectable, but still a majority remain unresectable. And at that time, the law of hepatic surgery for colorectal liver metastasis was to resect all or doing nothing. And so the problem I was faced with was what to do when, despite downsizing of bilobar liver metastasis, the remnant liver is too small. Of course, you can do sometime portal embolization, but at that time, when it is bilateral, you cannot do portal embolization because you will have a growing of the tumor in place. And so I proposed at that time to do, why not, an hepatectomy in 2 stages. And this is an example of a patient you have here with a remnant liver which is too small. And if you do right hepatectomy and a left lobectomy with only the segment 4 and segment 1 at that in one stage, you kill the patient. Why? Because the remnant liver was only 155 cc. So I decided to do at that time a right liver first approach. So I did a right hepatectomy. I wait for, I would say, around 1 month and a half, 2 months to have a consistent hypertrophy of the remnant liver. And when the remnant liver was sufficient, and you can see here the hypertrophy, I did the left lobectomy. And so this was the remnant liver in this patient who was alive for more than 8 years. And finally, he died from pulmonary metastasis, 8 years after the second operation on the liver. And by this, we create a new concept in hepatic surgery, meaning that when you cannot remove all the tumor in one step, you can possibly do it in 2 steps. And we move from this right first approach to the left liver first approach. You have here, I would say, the conventional, I would say, 2-stage hepatectomy today, who consists on removing all the liver lesion on the left liver, and we decide to move to that because in the same time, we do a right portal ligation with embolization. Here we inject absolute alcohol to try to destroy all the endothelium of the portal right system, in a way not to have, I would say, a cavernoma, and to have a real hypertrophy of the remnant left liver. And so we create, by the necessity of not being able to resect patient with bilateral metastasis in 1 stage, we create a new concept, which was the 2nd-stage hepatectomy. And we move from the right liver first approach to the left one, because as this is a limited hepatectomy, we can combine sometime the left liver first approach to a resection of the primary at the same time. And so the validation of this approach was made with a 42% 5-year survival, a little bit lower than conventional hepatectomy, but not so different. And this was also, I would say, approached by many teams in the world, showing that at 5 years, when we succeed to do the 2-stage, because the dropout may be important in such type of strategy, the survival at 5 years of efficiently done 2-stage hepatectomy is 42% at 5 years, which is very, very close to that of usual hepatectomy. And the third example of, I would say, chance and necessity is another problem. The problem was illustrated by this case. 2004, colorectal liver metastasis considered as an absolute contraindication to liver transplantation. And the question is what to do when, despite a good response to chemotherapy, there is no possibility to do any curative liver resection, even with a 2-stage hepatectomy. This is a good example because you have a miliary disease. You see that all the liver segments are occupied, are invaded by metastasis. And so even when you have a good response to chemo, in fact, you cannot be sure to make a curative hepatectomy, because what we know is that when a tumor disappears, some tumoral cells may persist, and at that time, you leave in place a lot of sites with potentially tumoral cell. And so impossible to do it. And this patient died 2.5 years after with 3 lines of chemotherapy. And we decided not to do a hepatectomy because it was impossible to do a curative hepatectomy. And so the question comes about, is it possible to do transplantation? But we know from the European experience of the 50 cases that the result was not so good. Only 18% survival at 5 years. As a comparison, 80% for patient transplanted for cirrhosis, as an example. However, because of that, of course, at that time in the year 2000 and 2010, liver metastasis from colorectal liver metastasis, an absolute contraindication for liver transplantation. But as you know, I was at that time, I had the chance to be, I would say, general manager of the European Liver Transplant Registry. I have also a big interest in colorectal liver metastasis, and I decided to explore what was the real outcome and why these 50 patients died at long term. And I noted at that time that 80% of these transplanted patients have been transplanted before 1995, at a period where the experience and the expertise of the surgical team was not so good in terms of transplantation. And I noted also, and this was the most important, that 44% of the deaths were in fact unrelated to tumor recurrence. So you see this 18% and you say 82% died from tumor. No, 44% of the deaths were unrelated to tumor recurrence. And at that time, I say myself, we should do something to revisit the indication of liver transplantation for colorectal liver metastasis. And in fact, I made a sort of brainstorming about what has changed, and I noticed, as also others, that all of the things have changed. Improved expertise in the management of liver transplantation, better knowledge of the biology of metastatic disease, better imaging, and mainly much more effective chemo. Because when this was published, in fact, we have only 5 FU. And the things have changed, and now we have much more effective chemotherapy, more adapted immunosuppression. And because I proposed to revisit the concept of liver transplantation for colorectal metastasis, a personal communication in 2004 at the Eurotransplant, I would say, meeting. And I proposed at that time, it was in 2004, that a reasonable hypothesis would be to consider liver transplantation for very selected patients with liver-only disease, modern imaging, confirmed unresectability, pre-op control of the tumor by active chemotherapy and routine adjuvant post-transplant treatment, and an adapted immunosuppression. And with this, we may significantly improve the result and offer long-term survival. There were around 100 people present in the audience, and a sort of survey was done, and everybody was convinced about this possibility. But everybody said me, this is impossible because we have organ shortage. But in the audience, there was one exception. And this exception was Axel Oslo Group in Norway. And he said me at that time, you have convinced me, and we will do in Norway. It's impossible to be done in the rest of Europe, but we will do in Norway. Because in Norway, we export not only salmon and oil, but also livers. We have more donors than recipients. And so what you are proposing, I will do it in Norway. And he did it. And we published together in Transplant International, liver transplantation, revisiting the concept and showing that the initial survival outcome of patients selected with a good chemotherapy, with the modern imaging and so on, survival. And so this was really new in the concept of transplantation for colorectal liver metastasis. And this prompted me to propose a multicentric randomized trial. I will be brief on this. This trial has been finished in August 2021. And the objective was to have a 50% 5-year survival minimum with a group of transplanted patients with chemotherapy, compared to only 10% with patients with chemotherapy. We have not still the result of this randomized study, but I think that within 6 months, we will have the definitive conclusion of this study. In parallel to all the chance I have had, and sometimes the opportunity I have been able to concretize, I have been dedicated to several scientific society. I have been president of the French Congress of Surgery, of the French Association of the HPB Surgery, secretary of the European Surgical Association, and now I'm involved as president-elect of the IHPBA, general manager of Villejuif. And so all this is important because you have also to help the, I would say, surgical community and to make your experience at the service of all the young, I would say, generation of HPB surgeons. And here you have my scientific production, of course, illustrating all this work done. And so I will finish by some slides saying, finally, if I make a summary, what may be the guidelines for this achievement? Very briefly, the first one is hard work, but very, very important. For me, it's the main factor. It's not the cleverness, it's not the, I would say, to be brilliant and so on. It's hard work, and hard work. The first one. The second is the passion. The third is the fighting spirit for patients, and also the strength of the teams that you may have around you. Alone, we may go faster, but together we can go further. And what I have learned in all, I would say, this cursus is that surgery is not a job, it is a patient. Surgery is also made by surgeon, but what is a surgeon? Surgeon is a physician who operates. So never forget that you should have a good reasonment, that you should be also a sort of a physician of the specialty you will do. And as an example, you should be a sort of hepatologist who make liver surgery, and not only a technician of liver surgery. Never forget also that clinical examination is the basis of your diagnosis. How many young surgeons are presenting cases in which they detail the MRI, the CT scans, the PET CT, and so on. And sometimes they forget to speak about the clinical situation of the patient. This is fundamental for me, really. The clinical situation is the basis of your diagnosis. Also for the patient, some advice is that I have learned from, I would say, my career is that we should have empathy for patients and offer them the best of your knowledge and skill. Because, of course, it's always much easier to say no rather than to say yes. But when it's possible to say yes, we should do our best. And also an advice, take your time. Quickness and quality are often not compatible. Because if not, we enter in what I may call the McDonaldization of our procedure. Do it quietly. Do it in the best way you can, but take your time. Be modest. The doubt is a school of truth, and we learn much more from our failures than from our success. But be also proud of your job. You save life, and surgeon is one of the most respected professions. And I will finish on some final advice. When you are in doubt about what type of specialty you should do, go where your heart takes you. Our job is fantastic, but sometimes difficult, stressful, and you should love it. And I remember always the sentence of John Cameron, which is a fantastic pancreatic surgeon of, I would say, of US. When I was a visiting professor in Johns Hopkins, he received me in his desk and so on. And he was saying, oh, it was 82 or 83 years old. And he was saying to me, you know, I'm doing less Whipple now at my age that I was doing when I was younger. But he was present every day in the hospital at 6 a.m. And he said to me, you know, when you find the work that you love, you stop working. This is not work, this is passion. And really, I think he's totally right. Another advice is to be attentive in all the innovation you can make in your practice. Of course, you will be criticized, but limits are made to be exceeded. And by definition, innovation is disruptive regarding the previous gold standard. What is important is that when you decide to do something innovative, you should do it on a collegial way with your team, and also measuring, I would say, the risk that the new procedure you propose may add to the patient. And be proud of your occupation. Surgery has a pivotal role to cure cancer and to save life. So this is the summary of what I wanted to say to you. And now, of course, I'm totally open to your question. Thank you.
Great talk, Dr. Adam. Really, it was very wonderful, and as one of the people said, encouraging lecture. So, John, any questions before I start? Because I have a lot of questions.
Okay, thank you, Cristina. Professor, you mentioned that early in your career, you was amazed and you valued the role of multidisciplinary management of these patients. I remember that you had a slide where you were explaining that there were differences in the results of the same type of surgeries or the same type of treatments in different hospitals around the world. And in that slide, you came to the conclusion that the factor that was associated with these differences was multidisciplinary management. Where multidisciplinary management was done, results were better. And I must say that I learned multidisciplinary management at Brousse. And but when we talk about multidisciplinary management, we should also talk about leadership. And I think this is important. And I would like to ask you, what's your view, what's the concept you have about leadership, and how you use this leadership to improve the results in our patients?
Mm-hmm. It's a very critical and also, I mean, I totally convinced as you that management of the patient is the best. Why? Take an example. Sometimes patient I referred directly to medical oncologists, and you have sometimes medical oncologists who are totally convinced that it is the only treatment to give to the patients. At the opposite situation, sometimes patient may be referred to the surgeon, and the surgeon does not believe in chemotherapy. It is an extreme situation, it's not always the case. And at that time, the surgeon will do sometimes only surgery without any chemotherapy. This is no more the case, but it has been the case for, I would say, many years before the situation today. I mean, surgeons are doing only surgery without any interest in chemo, and oncologists were doing only chemotherapy. And so the advantage, I would say, of the tumor board meeting is that everybody is in contact with the other specialties, radiologists, oncologists, surgeons, pathologists, biologists, and so on. And that this is the better way to prevent any, I would say, monopoly of treatment of, I would say, oncologists or of surgeon or sometimes interventional radiologists. Because another example is that if you are interventional radiologist and you ask your patient, what do you prefer? To have an incision or to have now with laparoscopic, it's I would say it's no more a good I would say a good argument, but sometimes you will be recovered for 5 or 6 or 7 days. What do you prefer, this, or you prefer to go into a day hospital and I burn your metastasis by radiofrequency? You are the patient. Of course, you will respond, I prefer to be treated in a day hospital by radiofrequency of my metastasis. But what is not said to the patient is that the results are not so carcinological complete, because sometimes we miss some lesion. That radiofrequency, when you have a tumor more than 2 centimeters, resection is better. And so the fact to be in a tumor board altogether avoids such type of extreme decision from one specialist without any regard to the other specialist. Now, what is important also is to do it in a friendly way. I know some country where, of course, if you have the head of the surgery, which is in conflict with the head of oncology, difficult to operate patient downsized by chemo, by radiation. And so the friendly way to communicate all together, to be modest, not to sometime, and this is much more frequent in our discipline than in the other one, but it's not always the case. Be modest, make for humility, and try to change the. It will be the best way to make that you will have a leadership, but a sort of soft leadership, not a leadership by power, but a leadership by action in what you show in your results.
Dr. René, Adam, how important is to have a mentor? Because not everybody could have Bismuth as a mentor. So how important is to have a mentor that just help you to follow the way, I think, and which is the advice I can say that, can you hear me?
Yes, there has been a problem of connection. So what is the importance of a mentor?
And which is your advice for the trainees or young fellows that want to be HPV surgeons?
Of course, I would be a sort of, it's the best situation, because a mentor has made a sort of running course that you have not done, and it will make you benefit from his experience or her experience. This is the ideal situation, but it is a sort of luxury. Not all, I would say, for example, my mentor was Henri Bismuth, but you may not have the monopoly. Henri Bismuth was the mentor of 100, if not 1,000 of surgeons, you know. And so the ideal situation is to be to have a personal mentor, some guide of your career, some guide who help you and so on. But I think if you are sufficiently, I would say, communicator, if you see the things very friendly, many mentors will come to you to advise. You know, you need to have only one. Of course, probably in your career, you will have 1, 2, 3 people who will emerge as the best one and so on, the people that you admire. But for the advancement of your career, you will have many, what I may call secondary mentors, which may be as useful as the main one, the big one, big figures and so on. So, I mean, the mentor, you suggest him or her by your action and your involvement. You know, every time you are faced with this, when you see a young surgeon who is very motivated, he come in the night to work and so on, automatically you become his mentor or her mentor, you know. I mean, Of course, it's the best to have it, but it is much more from you than from him or from her that it will come. You should provoke, I would say, the mentorship. It's not automatic.
For sure. There is some questions in the panel, most of them related to the treatment of colorectal liver mets, for sure. One of the two questions are related to the liver transplant. I want to ask you my first question. If you at least be a spoiler, if the results in liver transplant are okay, or you expected, how are the results going? And there is another question from the panel that says, how you face with immunosuppression after liver transplant? And if the 5-year survival of patients, the quality of 5-year survival of these patients transplanted because of colorectal is not. Dr. René Adam is gone, I think.
Yeah, I think he has some connection issues. I think he has some connection issues. Let's okay, he's back.
Okay.
Professor, can you hear us? Okay, to all the attendants to this webinar, please feel free to send your questions.
Right. Yeah.
Yes.
Okay. So I cut the video in a way to have much more power.
Okay. So I don't know if you heard my question about the colorectal liver mets and transplant.
No, I
start again.
Didn't catch. No,
okay.
No, I didn't catch
okay.
it.
My question from the liver transplant colorectal liver mets, if you can be like a spoiler and tell us a little bit, at least, the results. If I think we expected better results in liver transplant, you have this feeling or not? And there is another question in the chat about how do you face the immunosuppression after liver transplant, colorectal liver mets, and the quality of life 5 years after liver transplant in these patients.
Mm-hmm. So I will respond very honestly to you. We have not still the result because we have not freezed, I would say, the database, because we are still recruiting some results which were leaking in the database. So we have not the result. My impression by seeing, I would say, many patients who have been randomized in the transplantation group is that first we may have lung recurrence. This is clear. But we may have also patients totally alive, disease-free, now at more than 3 years, 4 years, 5 years, and with a totally disseminated disease as the miliary disease I showed you before. So now to say transplantation will do better than chemotherapy, much better than chemotherapy with the difference of 40% 5-year survival, I cannot say you this because we are waiting for the result. What is also sure is that because of the organ shortage, some patients were not transplanted, even randomized, because the time to wait for having an organ make that 18% of the patients were not transplanted. So it's a very important, I would say, proportion of patients, because waiting for the liver, you stop chemo and the tumor reprogress. So on the intention to treat, we should take into account that 18% of the patients randomized in the group of transplantation were not transplanted. And another point is that we should be very strict in the selection. The randomized study was associated to a steering committee with independent. And I can say use that 40% of the patients who were referred by expert tumor board were rejected from the eligibility criteria. Why? Because sometimes, and this is a totally human reaction, when you have a patient, a young patient, 40 years old, with disseminated liver, and you may have a small lung nodule, a small lymph node, you may say, oh, it is young, I'm totally empathic with him, with her, and so on. So we try to do transplantation. And you are not, I would say, rigorous for the indication. And this may explain why an independent committee is also important. And so finally, for the quality of life, fantastic. Fantastic. All the patients who are alive without recurrence, or even with a lung recurrence which has been operated on, finally enjoy a lot of their life. For the immunosuppression, we try to switch progressively tacrolimus to everolimus, but it is on the long term. It's not immediately after transplantation. It is 1 month, 2 months, 3 months, mainly 3 months after the transplantation that we switch progressively. We diminish the dose of tacrolimus and increase the dose of everolimus. But very frankly, I'm not so sure that we improve the result by doing this. We may assume, but we have no scientific proof. This is not evidence-based data.
And there's another question also. What is the ideal time to consider for the second stage of liver resection? After how many weeks do you imagine to see the status of hypertrophy? And during the time gap between 2 resections, do you consider continuing chemotherapy?
So we continue chemotherapy in the interval between the 2 stages. And I often say we are not in a hurry. This is a big contrast compared to the ALT procedure. My explanation of the big mortality and morbidity of ALT procedure is that because everyone wanted to operate the patient 10 days after the first stage, while the hypertrophy was sometimes not sufficient, while the patient was very tired because a lot of chemotherapy and so on. So in the 2-stage procedure, conventional one, what I'm saying is that we are not in a hurry. We should operate a patient who has recovered from the first stage clinically, who will not be in a progression of his disease. And of course, to avoid all this is to do chemotherapy in between. And you have sufficient hypertrophy. You are sure that no other lesion has appeared. At that time, you do the second stage. And so the mean time for that in our experience is 2 or 3 months, because we are not in a hurry, you know. And of course, the inconvenience of that is that sometimes you have patients with very aggressive tumor who are drop out from the second stage because of progression. Are we selecting the good case for having a good outcome? It is my conviction, but I cannot say that by hurrying it, we will avoid dropout, which is the case of ALPS. In the ALPS, by definition, you have no selection in between. But if you see the result at long term, it is not established today that the absence of dropout is translated in a better outcome of ALPS as compared to two-stage hepatectomy. So by not selecting the good patient, of course, we have more risk of recurrence and, of course, the less possibility to do a repeat hepatectomy in such type of patient. So anyway, interval chemotherapy, not in hurry, being sure that the patient is in a very stable situation, or even continuing downsizing of the tumor by chemotherapy to do the second stage. And of course, with a good hypertrophy.
So
I have one question for the audience. And this is a colleague from Algeria, and he's telling us that in the case of his country, personal efforts may remain insufficient they do a lot of training in France, and but sometimes having a mentor is very hard for them, and following the guidelines is not really obvious to them. What can we do for them? How can we help them?
You mean the guidelines are not followed? It's not simple to follow the guidelines?
For them, yes.
It's difficult to say don't follow the guidelines, the first point. The second point is that by going also by making stage in other, I would say, surgical department may help to gain experience, to gain also recognition from other, I would say, surgeon in the team. But I cannot do something different than recommending to follow, I would say, the guidelines for each indication of surgery. I think we should follow the guidelines. Now, when I'm saying that, sometimes we may be at the margin. And this comes to what I was saying. If you want to do innovation, by definition, if you follow every time the guidelines, you will never discover something new. By definition, you will follow. If I have followed, for example, for colorectal liver metastasis, if I have said, no, we have definitely demonstrated that the results are bad, of course, the liver transplantation could not be done today. When two stages is the same, sometimes you should be a little bit disruptive about what is admitted in the, I would say, in your specialty, and to go a little bit further or a little bit, I would say, around the guidelines to try to discover something. But you should have in mind that you should not be too risky for your patient. You should not be crazy. You should be innovative, but you should not be crazy. And so in such case, of course, you may be a little bit over the usual guidelines for any indication, but not so you should remain relatively close to the indication.
I think that in the case of liver surgery, especially, and where we have the aid of modern imaging, for them it could be difficult because they don't have such aid. They don't have contrast enhanced ultrasonography. They don't have modern CT scans or MRIs. And I have to say that I have some friends from Africa, and they are the surgeon, the oncologist, the radiotherapist, and sometimes even the endoscopist. They are a multidisciplinary team in themselves, you know, and so we have some examples. For example, for digestive surgery, where it's easier for them to skip some steps, but to have the patient in the safe path. But maybe in the case of HBP surgery, this could be even more difficult because we need some advanced images. You know, I think that this is difficult for them.
It's true, but my advice would be when you begin, I would say, an experience in any procedure and so on, my advice would be to choose the easiest patients. Why? Because in such way of multidisciplinary approach, if you choose a difficult patient in your initial experience, and of course you have bad results, the confidence of the gastroenterologist, of the oncologist, of the radiologist, they will say not the patient was in a too bad condition, they will say the surgeon is not so good. So my advice when you begin, and this has been true for liver transplantation, in many teams who began the liver transplantation, please choose the easiest patient. don't choose. It's a pity to have a patient in a very severe condition and so on. But if you operate patient the day before the death, of course, you will not gain the confidence of the rest of the specialties. So choose good patient, and then you will grow into, I would say, the severity of the different patient you will operate when you will have gained the confidence of all your staff, of all the other specialties. This is a way also to gain confidence.
And how difficult is to defend your own ideas, no, your own proposals when, I don't know, you are against to the others, or the others are not agree with, they don't agree with you. Even here in the chat, Bernardo Maria says there is a fine line between innovation and crazy science. Discipline and common sense must be present all the time. Man, when do you know that you are right? That you are not doing anything crazy?
Mm-hmm. It's a difficult question. I think to convince is, of course, to have first a good reasonment. And you may not be able to convince anybody if you say, oh, I have the idea to change this operative strategy and to do like this and like this. So, and why? And you say, no, it's my idea. It's not sufficient. Even if you cannot be able to bring evidence-based data. For example, I give you an example. An example I didn't mention. I'm defending now the, I would say, cytoreduction surgery in liver metastasis. Okay, and it could be also incorporated to other tumors. So if you say this today in a staff, everybody will be laughing, say you are totally crazy. The surgery should be total or not existing. But if you say we have model of tumors like neuroendocrine, like ovarian tumor, in which chemotherapy is so active and so efficient that sometimes not to be able to remove all the tumor is associated with a higher survival than only chemotherapy. So I would say my point is that when you try to do, I would say, an innovative procedure, or you want to convince something and you have no, I would say, evidence-based data, you should be convincing by, I would say, the argument you may provide, which makes that finally all the theory you propose is supported by these arguments. Of course, you cannot say, I'm a genius and I want to do something new without any arguments. But if you have, I would say, a different and several arguments with a good reason to provide them, at that time, people may say, oh, why not? But you know, there is a word that I like so much. It is the following one. When you do something,
the best part.
Is the first that you are doing, but mainly the enormous mass of people who are doing nothing.
Professor,
you know?
Professor, we missed you, so we don't know what you said.
So
we didn't
I
hear
repeat, I repeat what the
last
word,
minute.
The last minute, okay.
No,
so,
no, the last minute that we missed the last minute that you said.
The last? Oh, sorry, I'm so sorry.
The last seconds
okay,
that you said.
So I didn't know if you catch. Okay.
Yes, the last 30 seconds.
There are the last 30 seconds and then, okay, so if you have a very quick question or...
No.
That we missed.
We missed what you said in the last minute.
Okay, the last minute was the 3 obstacles, the people.
We're missing again.
It's a bit of an intrigue, you know. The suspense.
It's freezing.
Yeah. We're missing the pitfalls.
It was the best important part.
Yeah.
What he would say.
Now we need to. Well, Cristina, saying, okay, Professor Adam is here again.
Sorry, you hear me now?
Now, perfect.
Now we can hear you.
We were in the most important part of your answer. So
I hope that I repeat, when you choose to do something new, you will face with 3 obstacles. The first one is the people who are doing exactly the same you are doing, people who are doing the reverse that you are doing, and mainly the enormous mass of people who are doing nothing. So to try to convince, make that you may bring a reasonable argument, and by this way, but true new ideas are always rejected. Remember when the people was saying that the Earth was round. Nobody believes this. You know, so every time new ideas are always rejected. Always.
Yeah.
But by saying this in a reasonable way, you may convince more and more people. And finally, in your team, you may say, we are doing an open study on, I don't know, 10 patients, trying to check if this new strategy could be useful. And at that time, you will convince your team to do it. But do it with your team, never alone, because no.
Good advice. There is only 2 questions left, John. I don't know, Maria, we can ask him 2 last questions from the chat, because
Sure.
we are, okay. They ask, I want to ask if chemotherapy is always necessary to do chemotherapy before resection of liver metastasis. This is a tough question. And the second is the case of synchronous metastasis of local advanced rectal cancer. How to manage?
Mm-hmm. So neoadjuvant chemotherapy, when to do it? It's difficult to respond to this question. I would say very, very briefly. If you have only one metastasis, metachronos, it is demonstrated that in that case, neoadjuvant chemotherapy is probably not useful. I mean, one single metachronos, for example, colorectal cancer, and 1 year, 1.5 years after, you have a single metastasis. No benefit at all of any neoadjuvant chemotherapy. At the other extreme, you see at the consultation a patient in whom 5 metastases appeared in the right liver. You may do a right hepatectomy, but much better to begin by neoadjuvant chemotherapy before, to be sure that another lesion will not appear in the left liver, and to be sure that your procedure will be helpful for the patient. So my message is that the more important is the tumoral disease, even resectable, when you discover it, the more useful is the neoadjuvant chemotherapy to be done. Okay, and for synchronous in rectal cancer, I would say the liver first approach in those patients with bilateral metastasis of a rectal cancer is probably the best attitude. And recently, a paper has been published by Felice Giuliante on liver met survey, who in fact explore how to do with bilateral metastasis, even colon first, colon and liver at the same time, or liver first. And he showed very elegantly that in patients with bilateral colorectal liver metastasis, the liver first approach was the best to do. in terms of outcome in survival and disease-free survival. And of course, this applies particularly for rectal cancer, because if you want to do the ideal treatment in low and mid rectal cancer, meaning radiotherapy combined with chemo, if you have bilateral liver metastasis, much better to choose first to treat the liver metastasis, and when you succeed to do it, to come to a very good and standard approach of the rectal cancer with chemo and radiotherapy, and then the resection of the rectal cancer. So it's the ideal situation of the liver first, rectal cancer, in my view.
So, well, it was a great talk, Dr. Adam. I think we can be here for ages. But we're running out of time. So thanks, everybody. Johnn and René and Maria. I don't know, Johnn, if you want to say something.
Okay, thanks to you for the invitation. It was a real pleasure to exchange with you.
Yeah,
Thank
for
you
us
very
also.
much. Thank you very much to everyone. Maria, do you want to announce our next talk?
Oh, we do have a webinar that is going to happen tomorrow on isolated limb perfusion, and the next one on the legends in surgery is going to be in March. Don't remember the exact date. March 13. Yes. And then again, for those of you who want to have a look again at the webinar, you can find it on our YouTube channel or on the website. Yeah.
Thank you. Have a nice evening.
Thank you very much. Professor, thank you.
Thank you
very much.
Thank you for the invitation. Bye-bye.
Thank you. Bye.
Thank you.
Bye.
Thank you.
Thank you.
Thank you.
Bye. Bye, everyone.